This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Non-Invasive Ventilation for the Pediatric Patient. Upon completion of this AARC webcast, participants will be able to state common indications for non-invasive ventilation in the pediatric patient, discuss challenges associated with NIV in the pediatric patient, review available interface options for the pediatric patient, and discuss NIV management strategies. I am pleased to welcome Dana Evans. Ms. Evans is a respiratory therapist and neonatal pediatric specialist. She is the respiratory care manager at Mercy Children's Hospital in St. Louis, Missouri. Ms. Evans is very active in the Missouri Society for Respiratory Care and is an AARC Management Section member. Neither Dana nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Dana, welcome to the program.
Thank you, Shauna. Thank you for having me. Good afternoon, everyone. So as Shauna said, today we're going to talk about pediatric non-invasive ventilation, some of the challenges associated with that, and some successes in some of the research surrounding this modality for this particular pediatric population. So as we start, we'll start with the definition to get everyone on the same page. I think we probably all are aware that non-invasive ventilation is simply the application of positive pressure ventilation without the use of an advanced or artificial airway such as an endotracheal tube or tracheostomy. Now, NIV was widely used in the 1940s and 50s, but truly prototypes for this modality were described as early as the 1800s, though didn't really receive widespread acceptance until the 1900s when electricity was available, and really due to the large demand associated with the polio epidemics. So as early as 1928, when the iron lung was invented, we saw this use of non-invasive ventilation, not just in the pediatric population, but in all age groups, again, particularly because of the polio epidemic. Prior to 1960, we really saw non-invasive ventilation used as the exclusive means of ventilating patients outside of the anesthesia suite. So patients that had artificial airways were likely undergoing surgical procedures and were done using anesthesia machines. It wasn't until the 1950s when there was a very significant polio epidemic outbreak, in Copenhagen, when that particular area of the world exhausted all of the non-invasive ventilators, but they were truly forced to use invasive ventilation to care for these patients suffering from polio. What they found was the patients that were on invasive ventilation actually had better outcomes than those patients who were cared for using non-invasive ventilation. And shortly thereafter, the switch to invasive ventilation in acute care areas started occurring, and the use of non-invasive ventilation sort of went to the wayside. During that time, of course, non-invasive ventilation was really continued to be used, mostly for patients with neuromuscular disorders. But it really wasn't until the last 20 years or so when we've seen a resurgence of this technology, not just in adults, but as well as in pediatric patients, with most of the research being conducted over the past 20 years. And of course, the major driving force behind the use of non-invasive ventilation for all populations has been the desire to avoid all of the adverse complications that have been associated with invasive mechanical ventilation. So before we really get going here, I just wanted to poll the group and see how many of you would say that you are regularly using non-invasive ventilation in your pediatric population. think we'll wait just a few more seconds here to let everybody answer. This is also a test to see if you're listening. No, I'm just kidding. Okay. So it looks like most of you have answered here, and it looks like it's coming across as about 50-50, 50% using and 50% not using non-invasive ventilation regularly in the pediatric patient. So as a follow-up to that, and I think I know the answer to this one, just wanted to see what the group thinks about the complexities of non-invasive ventilation in the pediatric patient versus the adult patient. So would you say, how many of you would say that pediatric non-invasive ventilation is actually more complex in its use when comparing that to the adult non-invasive ventilation? Okay, so as your answers are still coming in, it's pretty overwhelmingly here that you would agree that pediatric NIV is more complicated than adult non-invasive ventilation. That would have been my suspicion as your response. Most things when we try and apply them to pediatric populations tends to be a little bit more complicated than it is with adult patients. So this is not outside the norm for most things that we do in the pediatric intensive care unit. So I want to talk briefly about a survey that was published in Pediatric Critical Care Medicine, in 2011. These researchers, Fanning et al., conducted a survey of just north of 900 pediatric physicians, with 38% of those folks responding, and they were asked, do you use non-invasive ventilation in your pediatric population? 99% of those respondents actually said that they did, so overwhelmingly, non-invasive ventilation is being used in PICUs around the country. 60% of those respondents actually reported using non-invasive ventilation as their initial form of support at least 10% of the time. So using non-invasive ventilation as a means to potentially avoid endotracheal intubation. And you can see, by and large, they were using non-invasive ventilation for patients suffering from lower airway disease, asthma included in that as well. And really the idea behind this survey was to help determine the use of non-invasive ventilation, so how many institutions are utilizing it, but also help to direct studies of non-invasive ventilation in children, as the data really is limited in this area as it concerns pediatric patients. So you can see, based on that survey, non-invasive ventilation is a vital modality. It's becoming more and more widely used in the pediatric population for pediatric patients. But unfortunately, there really is not very much available data on this subject. Lots of good research on adult patients, some pretty doggone good research on neonatal patients as well, but there seems to be a big gap in the literature when we talk about pediatric patients. In fact, there's only one randomized control trial looking at specifically pediatric non-invasive ventilation. All other data really is observational cases or case studies. it's interesting because the case studies really started appearing in the literature in the 90s, which the first one appearing in 93 was published in the Respiratory Care Journal, looking at two 12-year-old boys suffering from atelectasis and pulmonary edema. So, nearly 20 years later, in fact, we still don't have a large body of work on this, and again, just one randomized control trial that was conducted in 2008. So the question is, why do we use non-invasive ventilation? Why are we using it so much in the pediatric population, particularly when there's really very little data to support or refute its use in that population? So why are we doing that? And that study I showed you a few slides ago would indicate that most PICUs are at least using it in some form on their patients. And the truth is, the reason we use it is because it seems to work. Right? It seems to do all the things that we hope that it would do in the adult population. It seems to avoid invasive mechanical ventilation. So resourceful as we are as respiratory therapists, we give it a go, and it seems to be working for these patients. This is the one randomized controlled trial that's been published on non-invasive ventilation. This was published in the Journal of Pediatric Critical Care Medicine. And it compared the benefits of NIV to just standard therapy, non-ventilation, in children with acute respiratory failure. And the authors concluded, there's a direct quote here, non-invasive ventilation improves hypoxemia and the signs and symptoms of acute respiratory failure. And it seems to afford these patients protection from endotracheal intubation. So what they found was in patients that they used non-invasive ventilation, improvements in vital signs and PF ratio within 60 minutes, and a significantly lower intubation rate in the non-invasive group versus those patients that were really just left to ride. So this was the first study that really randomized patients and looked at this in a significant way. This study was an observational retrospective study, but I think it's a good one that looks at the rate of intubation or the lack of intubation for patients that are treated with non-invasive ventilation. So this is a 5-year study in a pediatric intensive care unit, again published in Pediatric Critical Care Medicine. This is from 2006. So it looked at all patients in a 5-year period. Over 100 of those folks were included, with more than 3/4 of patients that received non-invasive ventilation were able to successfully avoid invasive mechanical ventilation. So again, it seems to be working to avoid the dreaded ET tube. So again, what are the pathophysiologic, what are the big reasons we use it? Again, as I mentioned, to prevent intubation if at all possible. But also on the other side of the spectrum is to facilitate extubation. So those patients that are currently on invasive mechanical ventilation and you're hoping to extubate them, this seems like a step down, a viable step down approach in many patients to gradually take them off the positive pressure by first removing the endotracheal tube, but leaving them on some pressure non-invasively. The ability to prevent intubation and to facilitate extubation would, in theory at least, decrease overall invasive ventilator days for those patients, and then hopefully, in doing so, decrease overall ICU stay and cost to that patient in the facility. It does that by decreasing work of breathing, so it's offloading some of the work needed by the respiratory muscles, decreases energy expenditure with each breath, just like any positive pressure ventilation would do. It's been shown to improve vital signs, decrease heart rate, decrease respiratory rate. It increases alveolar ventilation by helping the patient achieve higher tidal volumes. Increases functional residual capacity with that PEEP or EPAP mechanism to decrease atelectasis in these patients, and can also be used to improve the effect or the significance of patients that have intrinsic PEEP due to chronic lung disease. So some of the advantages of non-invasive ventilation compared to invasive ventilation, you'll see a decreased risk of ventilator-associated events or ventilator-associated infections. Many patients that are on non-invasive ventilation have less pharmacologic need for sedation, less risk of barotrauma and volutrauma associated with NIV. If you don't have an endotracheal tube, the likelihood of the damage caused by the tube obviously goes way down, so the risk of tracheal and vocal cord injury is lessened without an endotracheal tube. As I mentioned in the previous slide, decreased ICU days, potentially, really associated with decreased ventilator days, which potentially decreases overall cost to the institution, which is certainly something that most institutions are very, very mindful of these days. Improved ability to tolerate feeding, so some of these patients on a full regular diet and have no need to be fed via NG or tube feeding, so they can continue to eat as they like. And then improved ability to communicate. So intubated patients are forced to scribble down and write us notes if they're able to do that. Of course, that's not really possible in a 3-year-old that can't write, but they're able to communicate to us in ways that they never could with an endotracheal tube on, so we would know exactly what that child is trying to convey to us. So I think this is really important in adults, but I think this communication piece becomes absolutely paramount for our little guys who don't really have any other means of communicating, whereas our adult patients, in a lot of cases, can write us notes when they're with it enough to do so. Some of the clinical indicators that would tip you off into thinking that maybe non-invasive ventilation is right for you. Patients in moderate to severe respiratory distress certainly should be considered for this. So they show signs of tachypnea, rapid heart rate, increased work of breathing retractions, nasal flaring in our little guys, particularly during bronchiolitis season. We see quite a bit of need for this. Some blood gas values. As you can imagine, patients that have an acidotic pH or an increase in CO2 might need a little bit of assistance, patients that are hypoxemic. I think the flip side to this is if you have a patient that has a pH less than 7.2, I wouldn't even consider wasting time with a non-invasive ventilator. I would go get a laryngoscope and intubate that patient. Those patients don't recover fast enough often non-invasively, so you end up being forced to intubate them. So hopefully you'll be able to facilitate quicker extubation using non-invasive ventilation. So certainly patients in respiratory distress should be considered, but patients that are already in respiratory failure probably should go ahead and be intubated so you don't waste time with fetal attempts with non-invasive ventilation. So here are some disease states that we commonly see used with non-invasive ventilation, although I think that the clinical symptoms and the pathology are much more important than just a listing of diagnoses. But these are some common diagnoses that we see for our patients who receive non-invasive ventilation. So those patients that are in acute respiratory distress or impending respiratory failure, neuromuscular disease, so smooth muscle atrophy, muscular dystrophy, upper airway obstruction, so kiddos with floppy airways or tracheal malacia, this might be able to help stent open their airways and facilitate respiration. Lower airway obstruction, so there's lots of discussion about using non-invasive ventilation for our patients suffering from status asthmaticus. As I mentioned, this is becoming a more popular modality for our little guys that come in severe respiratory distress associated with bronchiolitis. It can help to prevent or treat post-extubation atelectasis by imposing some PEEP, and used for patients with chronic respiratory failure as well. So some more indications. So as I mentioned, facilitate weaning from mechanical ventilation. Something that we have been doing more of that I think is always a bit controversial is the use of non-invasive ventilation for patients that are on palliative care or have orders to do not intubate. So as I said, this can be controversial, but certainly something to consider for patients that have a terminal or chronic illness, but perhaps the parent does not wish the child to be intubated or to receive a tracheostomy. So very often they may be suffering from an acute exacerbation of something unrelated to their illness. If they have SMA, they may be in with pneumonia, and using non-invasive ventilation might get them over the hump, if you will, of the acute exacerbation. Even though it won't change their long-term outcome, it might buy them a little bit more time with their family. So you can often manage them through that. And we have used it for children on palliative care to help facilitate getting them out of our ICU and getting them home to be with their parents. I think this is pretty significant for families who are going through particular terminal illness to be able to have that child at home with them rather than to spend the entire lifespan of their child in the ICU. So I'm seeing that used more and more commonly for those patients on palliative care. So some contraindications. So patients that have significant cardiovascular stability, if they're on vasopressors, you really probably wouldn't want to do this. You'd want to put them on invasive mechanical ventilation. To be on non-invasive ventilation, you have to be participating. So you can't be apneic and placed on non-invasive ventilation. You must be able to trigger the machine. If you have significant facial injury, you wouldn't be able to tolerate the interface. So if you have big bad facial burns or significant facial trauma, this is not something that we would always consider for those patients, at least not in the acute phase of that. Patients have to be able to protect their own airway, so if they are very, very confused or are have a really significantly decreased level of consciousness, they're not able to protect their own airway, so they shouldn't be on non-invasive. Or patients that are uncooperative or combative. So the only way this works is if you have a patient that can be compliant with not just the machine but with the interface. So they have to be willing and able, if you will, and be cooperative with the device. So uncooperative patients don't work. I actually got a call last week asking me if it was okay to restrain patients, to physically restrain a patient on non-invasive ventilation, and of course I said absolutely not. Patients have to be able to rip their own mask off in the case of if they throw up so they aren't aspirate. But again, that speaks to the fact that they have to be cooperative and non-combative to be a patient eligible for this modality. So speaking of that, I want to talk a little bit specifically about the challenges associated with non-invasive ventilation for these little guys. So this is pretty challenging. Those of you that work in the pediatric arena know this. We deal with little bitty babies all the way up to adults, so kiddos that were just discharged from the well baby nursery yesterday all the way up to about 18 years of age. So that's a huge swing, a huge continuum of patient size and type, and it's very, very difficult to say one size fits all with these kids, because that's absolutely not true. So finding an interface, a mask, nasal prongs, whatever it may be, to fit the child can be extraordinarily challenging. Actually find that kiddos under the age of 5 are probably the most challenging to fit. And then compliance with the device. These kiddos they're little, they're often scared, maybe they don't understand exactly what you're doing, and so that can be really challenging to make them understand the need to be compliant with the device and with the mask. It can be a challenge to find a unit, a machine to deliver the non-invasive ventilation that has flow rates that are appropriate for a small child. You don't want to blow them out of the water with big bad flow rates. But, you know, contrast, it also has to be something that the child can trigger. So it has to be sensitive enough that a small baby or toddler-aged child can trigger the device without auto-triggering continuously. So it's a delicate balance to walk. I think that this has gotten easier over time as more devices have become available and approved for pediatric patients, and we'll talk about that in a minute. These are more labor-intensive patients. It takes more time at the bedside with the patient to desensitize them to the interface, to get them compliant with the device. There were some studies published several years ago, although they looked at adult patients, but I think that this is, really translates well, and it found that patients, at least within the first 8 hours, are significantly more time-consuming when they're on non-invasive ventilation versus those that are not, or versus those patients that are intubated. So I'm sure I'm not telling you anything you don't know. Those patients do tend to be a bit more time-consuming. And caregiver education and understanding is a huge, huge hurdle that we have to jump. Everybody needs to understand what we're doing. Everybody needs to understand the importance of an interface that fits appropriately and not cinching it down on their face super, super tight. That includes mom, dad, grandma, grandpa, anybody, any caregiver in the room, bedside nurses, physicians, residents, and of course the respiratory therapist. So the entire care team really needs to be involved in the education portion and desensitization of the device. So as I mentioned, device selection is paramount, particularly with pediatric patients. Generally 2 types of machines available to deliver non-invasive ventilation. Those are the dedicated non-invasive units or a critical care mechanical ventilator, so your ICU ventilator. Some of our newer generation non-invasive units have been approved for pediatric use, so you'll see the Respironics V60 or the Trilogy have been approved for pediatric patients now. So they're a little bit easier to trigger. They have more compatible flow rates for our smallest patients and seem to work better than some of the older devices. Despite that, I think in some patients, our smallest babies, we here at our institution still continue to use the critical care ventilator for our smallest patients on non-invasive ventilation because it's used to ventilate much smaller children. So that seems to work better. But having said that, again, there's more devices out there that are just readily available for our patients. One of the bonuses to using a dedicated non-invasive unit is they tend to be better at compensating for leaks, though some of our newer generation mechanical ventilators are getting better, or some of them are pretty doggone good at it. They tend to have more features that are aimed at enhancing patient compliance and comfort, like leak compensation, some better adjustments with triggering or cycling mechanisms, rise time, e-sensitivity, stuff like that. So that's the machine. Let's say you've chosen the machine, you're ready to go, and now I think the even harder challenge again is to pick the interface. So which one will work for you? Which one will work for your patient? Which one will work for your patient's family, your nurse, the whole gang? And this is probably the most important decision you can make because choosing the right or wrong interface very often can mean the difference between success and failure in these kids. So you have some options, some of the same options that you have in the adult patients: nasal mask, full face masks, also known as oro-nasal masks, nasal prongs or pillows, and the full face shield. Now, the truth is there's very little evidence. Evidence is certainly lacking which interface would be considered, quote-unquote, the best, and that's true in the adult patients as well. But the truth is, the one that's the best is the device that your patient is going to feel the most comfortable on, and is willing to be, and is more likely to be more compliant on. So this often includes a dialogue with your patients. Now I realize you're probably not going to have a long dialogue with a 2-year-old about whether or not they want prongs or a face shield. But you can try those on with those kids and see which one works best for them. And if they absolutely hate it, and a 2-year-old will let you know if they hate it, maybe you should try a different interface and see if that's more successful. So this slide is full of several interfaces, probably some of the more common interfaces seen in the pediatric patients. Now, my personal bias here is that we have the biggest challenge with preschool age toddler children or early elementary school kids and getting them fit. So finding an interface that actually fits them, but also a headgear that actually fits them. We've got some kids that maybe we can get a mask on, but the headgear is so large that we feel like we almost want to wrap it around their head a couple of times before we get the Velcro to match up. So that probably isn't going to work for them. So it has to be both the headgear and the interface that works well for that child, and sometimes finding that perfect combination can be really, really difficult. So some of the masks you see there, the Respironics PN831 and the Respironics AF531, that's a nasal and oro-nasal mask respectively. Both of those devices are available. The AF531 is really only for kiddos that are 20 kilos and bigger, so 7-year-olds, give or take. Whereas the PN831 has actually been approved for kiddos 1 year or older or 7 kilos. The Respironics Performax has been approved for kiddos 1 year or older. The KidSta, like the AF531, really is for bigger children, as you can see in the photo. The ResMed Pixie is a nice one that is specifically designed for kiddos between 2 and 7, although we have used it for kids younger than that in some cases. CareFusion Mini-Me also works for little bitty guys. We just sent a kiddo that was 8 months old home using a CareFusion Mini-Me and worked pretty doggone well for that child. And then the Neotech ROM cannula. So those of you that work in neonatal intensive care units, you may be familiar with this product. Hit the market about 1.5 years ago, and we use it a whole lot in our NICU for non-invasive ventilation. But we're also starting to take it up to our PICU to use for non-invasive ventilation for small infants. So that kiddo that I mentioned that just got discharged from the Well Baby Nursery 2 days ago and is now back, we might use that child, or use non-invasive ventilation with that child on a ROM cannula so long as it fits them. So one of the neat things about that, that's a Neotech product. They're actually working currently to develop a pediatric-sized cannula, so to extend the use of that device even further in the PICU. And I'm certainly looking forward to that, because the one thing about that device, and you guys can probably see this, is it doesn't have a headgear. So it takes away that second component. I mentioned that you had to find an interface that fit them, but also a headgear. Well, you still have to ensure that this cannula fits the child. Doesn't work for every single child, but the nice thing about it is you take away that added does the headgear fit piece, because there is no headgear. It also seems to ease fears for our patients. It looks a little bit, more, again, quote unquote, normal, less invasive, if you will, and they tend to be a little bit more compliant with it. So I'm looking forward to that. It certainly doesn't work for everyone, but it's nice to have another tool in our belt, given that really there just aren't a lot of options available for our small patients. So just general sizing and application tips, regardless of what you choose, what device you choose. You want to be sure that you initiate gas flow on whatever unit you've chosen before putting the mask on the patient. Many of these masks sort of puff up, at least at the junction where it would touch the patient's face. And if you put it on the patient before you turn on the flow, you very often will have it too tight, and it doesn't allow the mask to puff up and sort of seal all the leaks that could be present there. So you have to let the mask do its job, and the way to do that is turn on the gas flow first. The gel masks don't really do that, but you still want to turn on the flow first. And then whichever mask you've chosen, if it's the oro-nasal mask, the pixie mask, just the nasal mask, you want to place the base of the mask on the face first and then roll it up into position. Once you've rolled it up into position, then you want to adjust the bottom strap. If it has two straps, you want to adjust the bottom strap first and get that nice and snug, and do the top strap first, or second rather. And if you follow this simple guideline, turning on the flow, starting at the base, doing the bottom first and then the top, you're less likely to over-tighten the device. And we know that over-tightening of the headgear can be really uncomfortable for your patient, but can also lead to those dreaded skin breakdown events in patients. So we want to avoid that. This slide is really important for our nurses to know as well. If the patient's popping off and having lunch or talking to grandma or having ice chips, they need to know how to put that mask back on appropriately. And we also need to spend a little bit of time with mommy and daddy and teaching them the same techniques as they engage with their child, so they're not inadvertently putting their kiddo at risk for skin breakdown. And I think that you need to make them, some of this I just said, but you need to also be really clear with them about the potential consequences associated with inappropriate mask placement. Of course, no one comes to work with the hope of maliciously injuring a child, and so when we end up with masks that are too tight, that's an education piece that's missing, not a malicious intent there. Certainly, I think we would all agree with that. So we need to be educating all caregivers, all members of the medical team, with the potential consequence of inappropriate application is for these kiddos. So compliance is absolutely probably the #1 reason patients fail non-invasive ventilation. So desensitization is a big subject here. So it's important to remember that children are not just teeny tiny adults. You have to spend time with these kids to get them accustomed to the mask whenever possible. If they're an impending respiratory failure, you don't always have that luxury to have that conversation with them. And sometimes it's a quick conversation with the child and the parent as you're quickly applying that mask to them, and that education might come later. But if you're given the luxury of being able to do it beforehand, that always works so much better, to allow them to see the mask, to see the headgear, to feel the flow coming out of the machine. Really our role is to be a facilitator to motivate that patient and the caregivers and their parents, grandma, grandpa, aunt, uncle, around the importance of that equipment, what we're using it to avoid, so avoiding endotracheal intubation, and really helping those kiddos take a minute to understand exactly what we're doing. So clear, age-appropriate language is important. I wouldn't use big words with a 2-year-old. I might just tell them that this mask is going to help them breathe better, and deal with their fears around that. They can still talk. They can still eat. If they get older, those are questions they might ask. Engage the parents. So if the parents can help you apply the mask, sometimes that's less frightening to a child. And being creative, really, really important. being creative. You know, I've had sometimes leave an extra mask in the room for the kid to play with if you have the luxury of doing that. Putting a mask on a teddy bear so they can see what that looks like. Letting them look at themselves in the mask. Some kids think it's really awesome and they're playing dress up and they've got the mask on. Some kids are so sick they could care less and would almost tolerate anything that you do to them. But it's important, again, to engage everyone in the care team around the education and to hopefully allow the child some time to play with it. Again, if it was an impending respiratory failure situation, you did not have that luxury, get that child on the mask, and maybe while they're on the mask you could take the time to chat with them while they're being cared for with the machine. So very, very important aspect to non-invasive ventilation is desensitization as it leads to compliance. So briefly, just a couple of words here about humidification with non-invasive ventilation. So really, HMEs are not recommended, not really thought to be as effective as a heated humidification system. It's really difficult to charge an HME, particularly if you're using a single limb circuit and the patient isn't exhaling back through it. And HMEs have been associated with increased minute ventilation and higher PaCO2s, really due to increased resistance to gas flow through that device. So generally, patients, particularly in acute exacerbations, it's recommended that you use a heated system, either heated wires or a passover system. This helps to reduce the worker breathing and really is a much more effective means of providing humidification to those patients. So as I said, there was very little data on this. There's very little data, as I said, there was very little data on mask and interface selection, not just in kids, but in everyone. I would say the same is largely true regarding mode and setting selections, particularly in pediatric patients. Again, this has not been well studied by any means. But generally, you can almost use any mode you want to provide non-invasive ventilation, particularly if you're using your critical care ventilator. You know, reading an article from Chatburn in 2009 in the Respiratory Care Journal, he would probably tell you that PCIMV plus PS, also known as spontaneous timed, if you're familiar with the Respironics devices, is the most commonly and potentially the most effective mode available for non-invasive ventilation. But certainly, you know, CPAP and pressure support are not uncommon. You can do lots of other things. So if you're using, you know, your Draeger, for example, you could probably put that child on any mode you wanted. But most commonly, we see a pressure-controlled IMV situation with pressure support. So going forth in that vein, some initial settings you might see. So for a patient that if you're using it prior to intubation or in an effort to avoid intubation for kiddos in acute respiratory failure, you might consider using, again, PCIMV plus pressure support with an inspiratory positive airway pressure of around 8 to 10 centimeters of water pressure above PEEP in many cases, then adjusting it for your target tidal volume. So if you're shooting for, you know, 6 mils per kilo, you'd want to titrate that pressure just like you would in an invasive situation, titrating the pressure until you achieve the volume that you were shooting for in those kiddos. The other side of the, on the expiratory phase, expiratory positive airway pressure or PEEP. Some general recommendations are to start around 4 to 6 centimeters of water pressure and then adjusting upwards to improve oxygenation, so monitoring chest x-rays, looking for adequate inflation, no improvement or improvement in atelectasis. Rise time is really, really important here. Rise time being the speed at which the breath is delivered to your patient. So each machine tends to do this a little bit differently, so I encourage you to get in your user manual and figure out what the numbers mean as it relates to rise time. Some machines use seconds, some just use arbitrary numbers, and so you need to know, is 1 faster or is 9 faster when it concerns your patient. A lot of people will start kind of in the middle here and will titrate for patient comfort. So, you know, slower might be more comfortable for most patients rather than being slapped in the face every breath with rapid achievement of your inspiratory pressure. And then of course FiO2 should be adjusted for target saturations. So this is one school of thought of doing this. Another school of thought would be to start with higher IPAPs, around 20, and titrate downward. So the opposite. So in this scenario, I'm suggesting starting at 8 or 10 and then adjusting up for target volume. That seems to work better for patient compliance. Some authors suggest starting higher at pressures of 20 and then titrating downward. The idea behind that being that you might achieve appropriate alveolar ventilation sooner. There is no data that directly compares those two techniques. So we can't really definitively say which way is better. Sort of subjectively, I would suggest, at least in what I've seen in my practice, is that the method that I have on the slide here is better tolerated by our patients rather than starting off at huge pressures that would be really, really uncomfortable to them, and starting off at lower pressures and then slowly titrating up. That seems to work better in terms of maintaining compliance with our patients. And again, if they're not compliant, it doesn't matter what we do, because if they're not wearing the mask, it can't be effective at all. So again, two different approaches, but this would be my preference personally. So sort of another way to look at this is, so the previous slide really looked at prevention, settings to prevent intubation. This particular study looked at settings and suggested settings for facilitation of extubation. This was published in BMC Pediatrics in 2010. And of course, they found that extubation failure rate decreased when they used non-invasive ventilation immediately. And those authors found that suggesting you use IPAPs between 6 and 8 and an EPAP of 1 to 2 centimeters of pressure higher than the PEEP that you had on the ventilator. And they reevaluated those children over 48 hours and over 12 hours. And what they found was those kiddos that were placed on non-invasive ventilation immediately after extubation did better than those that were placed on as a rescue means, so when they started to fail. And these are the settings that they chose to use as sort of the proactive, immediate extubation approach, and were pretty successful with that technique. So advanced settings, I just talked about rise time being that speed at which peak airway pressure or inspiratory positive airway pressure is achieved, and again is related to patient comfort and compliance. Expiratory sensitivity, E-sense, E-termination, lots of different words for this. It's a fancy way of saying when the breath ends, usually based on a percentage of peak flow or time. Again, non-invasive ventilation inherently has quite a few leaks, so you want to make sure that your expiratory sensitivity when the breath is able to end is set appropriately for your patient. If you see a kiddo really working to exhale or having difficulty ending a breath, then you need to evaluate where your expiratory sensitivity is set, and that may need to be more sensitive than where you have it currently to, again, ensure patient comfort. On the flip side, if you have it set too sensitively, you'll end up compromising the patient's delivered tidal volume. So you want to be cognizant of that and find, again, that balance that makes it easy for them to exhale but still allows them to reach the tidal volume that you're shooting for. Leak compensation. So you need to have a device that can measure and ideally measure and compensate for leaks. So most our freestanding non-invasive devices are able to do that pretty efficiently. A lot of our newer generation ventilators have non-invasive settings, and they're able to adjust for leaks in the system as well. So that's perfect. You should expect there ought to be a leak present in non-invasive ventilation. I would tell you if you do not have a leak, then the mask is too doggone tight. You're putting your patient at risk for skin breakdown, so there has to be a leak there. If you look at, if you're using a Respironics device, they actually recommend that you have a leak somewhere between 7 and 25 liters per minute. So you want to make sure that there is some leak present there. Leak compensation is really important, again, because it compensates. It measures and then compensates for the leak that's coming out around the mask or maybe through the whisper valve or exhalation valve. This allows for consistent maintenance of your EPAP, helps to prevent auto-triggering, which is the case when you have a big bad leak. If you don't know that it's there, it can cause auto-triggering and make your patient very uncomfortable. And then it can also improve tidal volume delivery, because you don't want your tidal volume being pumped out to the room. You want it to be delivered to your patient. So leak compensation is very, very important. I encourage you to grab whatever device that you're using at your institution and figure out exactly how it sets and how rise time is utilized. Same thing with e-sensitivity, and to know how leak compensation works with whatever device you're using in your institution. So complications, potential complications associated with non-invasive ventilation. So this is not, of course, not limited to pediatric patients, but it's true of most non-invasive ventilation. So our kiddos are at risk for skin irritation, breakdown up until pretty significant breakdown, nasal dryness, maybe a bloody nose, eye irritation if there's a big leak up near the bridge of the nose and blowing in the eyes. There is risk of aspiration, particularly if they are vomiting, so you have to be cautious about that. And you have to be careful when they're eating as well. I once took care of a very, very morbidly obese 14-year-old boy who thought it was a good idea to eat fried chicken while he was on non-invasive ventilation. And bless his heart, he ended up inhaling and aspirating a couple of, believe it or not, chicken bones. So we have to use caution when our patients are on non-invasive ventilation for that as well. So skin breakdown, also known as hospital-acquired pressure ulcers. This is a huge, huge issue. It's very difficult to manage. It can be quite expensive, up to and including some litigation issues with these kids, particularly if it involves plastic surgery. So we have to be cautious and conscientious of preventing these. So really any pressure ulcer develops when soft tissue is compressed between a bony surface and something else for an extended period of time. And just for your knowledge, so CMS really has said that stage 3 and stage 4 pressure ulcers are preventable, which is code for we won't pay for that. So you have to be cautious about that. Now most of the time we can identify at least the beginning stages of these long before they get to stage 3 and stage 4. And it really is a multidisciplinary effort. It takes all members, again, of the care team to ensure this does not happen to the child. So skin breakdown can happen pretty doggone quickly and as rapidly as a few hours of ventilation for those patients that are at high risk for developing a pressure ulcer, particularly across the bridge of the nose, but certainly can be more extensive than that. If you're using nasal prongs or nasal pillows, you have to be cautious of the septum as well. With the reported occurrence of skin breakdown and non-invasive ventilation, really, if you look at the literature, being anywhere between 2 and 23%. So that's a pretty wide range of occurrence there. So we need to be doing skin assessment. We need to look at the integrity of our skin, being really attentive to these little guys, particularly those that might be considered at high risk or have several risk factors. So you should look at their skin before you ever put the mask on their face and make sure that the skin is intact. So, patients that are at higher risk of developing pressure ulcers are going to be your older patients or your significantly small patients, your neonates, those that have poor nutrition, because poor nutrition actually affects the integrity of the skin and the ability of wounds to heal. If they have current or pre-existing pressure ulcers, they've had them in the past. If they have diabetes, this might be something to consider. Or if you think you're going to be on non-invasive ventilation for extended periods of time, these are the patients that might require some additional observation and potentially intervention in order to prevent pressure ulcers. So how frequently should you be looking at this? I think this varies by institution. At our institution, I would suggest that every single person, every single time they take off that mask or move the interface, they should be looking at the skin. And they're not just for clear breakdown. We really need to be looking for redness or blanching of the skin, and then you should take action. So we actually require our therapist to document even redness, even blanching. And when they document those things, we also require that they document the intervention they took to prevent the pressure ulcer from occurring at that point. So that might mean having 2 different types of interfaces available for your patient. So you might use an oronasal mask and the face shield, changing the pressure points on those patients in order to prevent the skin breakdown, which is actually pretty successful for us in terms of alternating that. And we tend to do it every 4 to 6 hours in our patients if possible. Some patients a little bit longer than that, but that seems to help, you know, in terms of changing those pressure points. Should you use commercial devices to protect the skin? You know, I think this depends on who you ask. The Wound Ostomy Incontinence Nursing Society published a position statement in 2010 on prevention and management of pressure ulcers in general, and they just sort of generically said that transparent films may be used on the face of individuals on NIV. But you know, what device should you use? Should you use it on every patient? You know, some places use Duoderm, other places use Mupilex because it's a little bit breathable. It doesn't change the fact that the mask is going to put pressure on the bridge of the nose. It might just provide an extra layer of protection from maybe friction injury. And I think friction injury really comes from inappropriately sized or inappropriately placed masks in a lot of cases. But you need to be able to look at that anyway. So even if you're wearing Mupilex, you really need to be able to take the mask off and look at the skin, and really also be able to pull up and look at the skin underneath the Mupilex. So some places, if they meet those risk factors from a couple of slides ago, will go ahead and put a skin protectant of some sort on the skin. Other places will not do that until some sort of until the skin starts to show issues, potential beginning of breakdown, and there really is no literature to say which way is better. There are some studies ongoing right now looking at specific to non-invasive ventilation, what causes this breakdown, and specific interventions that might alleviate or you know, prevent some of this from occurring. But those are, like I said, currently undergoing, and I look very much forward to seeing what the results of those studies are, because this is becoming more and more significant in our practice and something we need to be very attentive to in our patients. So I want to go through a couple case studies. So the first case study, talking about facilitation of weaning. So these are real case studies that we saw in our pediatric intensive care unit. So this little angel is a 4-month-old, 6-kilogram kiddo who came into the ED suffering from respiratory distress. It was grunting, retracting, nasal flaring, febrile. So, you know, diagnosed with pneumonia and respiratory failure. Ended up being intubated. I started off on a nasal cannula, really could not oxygenate the patient. And the blood gas obtained in the ED, the VBG, is in front of you there with a pH of 721 and the CO2 of 61. So that kiddo was intubated in the emergency department at that time, rather than pushed on non-invasive ventilation because of the pH and because of the significance in work of breathing, and placed on a transcutaneous monitor and titrated throughout the stay using the monitor and blood gases. Every time they tried to wean this child down to less respiratory support invasively, the child would have significant increases in respiratory rate and increased need for oxygen. So after 10 days, they did go ahead and attempt extubation in this patient. Felt like they were as low as they were going to get without just straight extubating the child, and ended up extubating to non-invasive ventilation. Because the kiddo was 4 months old, we chose to leave them on the critical care ventilator and used a ROM cannula actually to provide the non-invasive ventilation, and put the kiddo on PCSIMV plus pressure support, which would have been spontaneous timed for you Respironics folks, with a peak inspiratory pressure of 18, a PEEP of 5, and a set respiratory rate of 12. And the child was very, very successful in that way, remained on non-invasive ventilation for 4 days and was successfully extubated to a nasal cannula after only 4 days. So in this kiddo, we really were unsuccessful. We were not going to get that kid extubated and had been on the vent again for 10 days. So really allowed us to speed up the process of extubation and was able to get that kiddo successfully off invasive ventilation, and again was on non-invasive ventilation only for a few days and did very well. Another kiddo that we actually just recently saw, a 7-month-old with SMA type 1 on palliative care. So had come in, again, with actually a pneumonia. And they were trying to get this child home. So, you know, the outcome with SMA type 1 is not good. So, again, a child was 7 months old. And so really just trying to get the kiddo home, could not get the child off. And this child was a do not intubate as well. So we did not intubate this child. It was actually in high flow delivery, and really trying to care for this child to prevent intubation and find a means of getting the baby home to be with their parents. So this child was placed initially on a ROM cannula on a Trilogy ventilator, but what we found was that particular child was unable to trigger breaths using the ROM cannula and the Trilogy. That was not a good that was not compatible for this child, although I've seen it work in other children. So they actually ended up transitioning this kiddo to a mini-me mask. So tried lots of interfaces, ended up settling particularly on this kiddo on a mini-me mask, and placed the kiddo on the settings you see there, an IPAP of 14, an EPAP of 6, and a rate of 20. So again, the PCIMV plus pressure support. And we're able to successfully ventilate this child and prevent atelectasis. Certainly something this kiddo was having was worsening and increasing incidence of atelectasis, and in this case a little bit of pneumonia. So prior to discharge, we actually again put the kiddo on the Trilogy, had them on the Trilogy for a few days, and we're successful in being able to get that child to go home with these blood gases immediately prior to discharge. So that kiddo is currently at home on the Trilogy ventilator and is able to be with his family. Really, so just a great, well, as great as you're going to get, the best outcome we could do for that family, to let them have some private time with their child rather than spending every waking hour in the PICU with us. So in summary, you know, most of the research on non-invasive ventilation has really been done on adults and neonates. Very little data available on peds specifically, but despite that fact, we are using it in lots and lots of ICUs around the country, and it has been shown to be a successful option, a viable alternative to invasive ventilation in many kiddos, and facilitates extubation. I think we absolutely need more options for interfaces in these children, particularly for that pre-K toddler age. And we need more data. You know, this is a call to action, if you will. We need more data, more research to be completed to validate this technique and to look at different modalities for these kids. And this only works if you are a strong clinician, a strong patient advocate. If you're with your patient, you know the device you need to be using, you understand the settings, you spend time with them, you're choosing the right interface, and you're assessing and reassessing your patient. So very, very important stuff. That's all I have, so I'm happy to entertain questions if anyone has
Dana,
those.
thanks for joining us today. For those of you watching as a live presentation, please stay with us during the next brief pause. If you're watching this as an archive, this concludes our presentation.